Welcome to another episode of Stories from the Edge of Life. We have a very special guest today, Dr. Charles von Gunten. Dr. von Gunten, would you mind introducing yourself to our audience, please?
My name is Charles von Gunten. I'm editor-in-chief of Journal of Palliative Medicine.
All right. I think you're a lot more than that, Dr. von Gunten. Uh, we'll get to know and hear some of it as we proceed with the interview. I'm Parag Bharadwaj. I'm a hospice and palliative medicine physician in the US, and I train under Dr. von Gunten. Just want everybody to know it's just an honor to have him today. Dr. von Gunten, want to hear your journey about, how you got interested in medicine and the trajectory of your career. Would you mind sharing, your experience?
Happy to. I started down the path of a career in medicine because my mother thought I should be a doctor. And like all good eldest sons, I did what my mother said and went to college and applied to medical school. Initially, I didn't get in, and so I entered a PhD program in biochemistry and earned a PhD in biochemistry. But I also then subsequently or concurrently got into medical school. But like I think all physicians, you really become a physician when you enter your postgraduate training. And so what was formative for me was doing my residency training in internal medicine at Northwestern University in Chicago. And it was there during my internship, taking care of real patients in a large general hospital, that I recognized this was the right path for me, that I wasn't a bench researcher. I like taking care of patients. And I'm also influenced by that, the tradition of medicine, the Hippocratic Oath. We are grateful for all those who teach us. We try and build up the field, make our additions as best we can, and then pass it off to others so they can continue to grow and develop. So it was at Northwestern where I saw patients who had advanced illness. And what I didn't know when I first went there was Northwestern Memorial Hospital, the teaching hospital, which was a large community teaching hospital, had a hospice unit. And as an intern, we were admitting patients all through the hospital, but including in the hospice unit. And it was so formative to me because dropping in there in the middle of the night, admitting patients, I was exposed to a different approach to taking care of patients. And yet the patients themselves weren't different than patients I was admitting in the ICU or elsewhere in the hospital, but the care was different. And that was striking. One of those formative places was I admitted a woman with advanced breast cancer in the middle of the night. And well, it's true for you as all physicians. In the beginning, you do things by rote. I knew what the admission protocol was. So in addition to doing a history and a physical examination, of course, I ordered laboratory studies and x-rays because that's what you did. And it was the nurse who very wisely didn't say, well, Dr. von Gunten, this is a hospice, we don't do that. Instead, she said, well, Dr. von Gunten, I see you ordered lab studies. Why? What will you do differently with these results? And that stopped me in my tracks. I wasn't thinking about why. I did it because that was what I was supposed to do. It set me on this trajectory of, well, why do we do this? And I remember I said, well, I think the woman is dehydrated. I need to know her blood urea nitrogen level and her creatinine. And the nurse said, well, do you think she's dehydrated from your examination? And I said, yes. And she said, well, we can do an IV, but I don't want to stick her twice for labs and then start an IV later. Can I start an IV and we can draw the labs at the time I start the IV? And of course, it made perfect sense. I said, yes. And I said, well, we need to do a chest x-ray. And she said, well, what will you do differently? And I said, well, I think she might have pneumonia. And she said, well, uh, does your physical exam suggest pneumonia? Are you planning to treat the pneumonia? And I said, well, no, we're not planning to do antibiotics. I was thinking, well, I had to have the results for morning rounds. And she said, well, we can get the x-ray, but I'm not going to send her tonight because she needs to sleep. And they'll keep her down in radiography all night long, waiting for it, and it'll be too uncomfortable. And since you're not going to change anything tonight, let's do it in the morning. Well, that made perfect sense. But the idea that you could approach the care of patients with an idea of what their experience is and balance it with what I was trying to achieve as a physician, that was different than everywhere else. And that captured my imagination, as well as the partnership. Nursing and weren't there just to observe and report. They were experienced. They brought a perspective that I didn't have. And I thought that was fantastic. So the rest of my residency, I stayed in close touch with the hospice unit. There was an empty office on the unit, which when I did a rotation in an elective in my second year, I decided to continue using that office. Nobody objected, and I was happy to help the nurses with orders or seeing patients. I felt like a member of the team. And when it came time then to decide about specialization, there was no career path in palliative medicine in the US at that time. This was, I started my residency in 1988, but oncology was the obvious path. And what I learned in my residency, not just by exposure through the hospice, but with patients, I enjoyed the relationships. I enjoyed the relationships with patients and their families. And it's my nature. I enjoy serious conversations. I don't enjoy small talk. And the thing that distinguishes cancer patients from all the other patients, at least during residency, is they were willing to have a deep relationship with their physicians. The barrier was on my side. My willingness to ask open-ended questions, and patients would answer completely, fully. They would expose themselves and their relationships, their deepest worries, their deepest perceptions, their hopes and dreams. I found that really spoke to my reason for wanting to be a physician, to try and help and partner, but also to understand and be curious about what it was like having their illness. So that was the reason for me to choose a career in medical oncology. And then at the end of my residency and at the end of my fellowship training, the medical director of the hospice, Jamie Von Rowan, who had been a role model and a deep mentor to me, said she wanted to give up being the medical director of the hospice and thought I should do it. And the chief of the division of medical oncology, Sig Weitzman, thought that was a great idea. And I said, fine, I'm happy to do it. I'm eager. I'd been reading about palliative care consult services in hospitals. I wanted to do that. Would he support that? He said yes. And so that was my clinical path. And I've never looked back. And my mother, I credit her for observing, okay, this is what my son seems to be good at. I see a future for him. But it was in that transition, particularly in fellowship in oncology and getting into hospice and palliative medicine, when that really took hold. And this is the perfect place. I remember early as a junior attending, at the end of long days, pinching myself, thinking, it can't be any better than this. I'm doing important work. It's meaningful to me. It's useful for patients and families. There couldn't be anything better. So that's the summary.
That's great. Yeah, so a few things. I made a few notes. So it's interesting that your mother, uh, you know, suggested that you become a physician, and then when you started your internship, you felt, hey, this is the right place for me, and you felt at home with that decision. You moved on to be the person who is very much responsible for hospice and palliative medicine becoming a subspecialty in the United States. So when you started your career, did you ever think that you would end up there at some point in time? And if you wouldn't mind also sharing what that journey was like in terms of the field being recognized.
No, I never dreamed I'd have the career that I have had when I started out. I remember in those early days of finishing my training and becoming an attending physician to which other people were looking for the answers. And I'm a planner by nature, and I was distraught. What was my future going to be? And I had been, well, I like to read, I like to study, and Sir William Osler, who really is the physician who is responsible for the shape of certainly American medicine, and many would say Western medicine in general, was shaped by this physician. And his lectures, his speeches to medical students and trainees are recorded in a volume, and so I read them. And Osler was very clear that you don't need to plan the future. You focus on the work of the day, and the future becomes clear as it evolves. And that was an enormous relief to me, that if Osler, who changed medicine writ large, used that, I could use that, and I felt off the hook. I would just focus on what I needed to do for the day and what presented itself. So the I serendipity plays such an important role in life. And for me, being at Northwestern Memorial Hospital in Chicago, it just happens that Northwestern is a very short few blocks from the American Medical Association's office, from the Accreditation Council for Graduate Medical Education office. So in my enthusiasm for taking care of patients, seeing them in the broader hospital, in the outpatient setting in oncology, in the dedicated inpatient hospice unit, and seeing patients at home, the, the, the response of the attending physicians, the larger community at the hospital, was so profound. When I started doing the work, started seeing patients, calling them, offering advice for how they would be managed, offering to talk to patients and families, help have the bad news conversation. The overwhelming response was, thank you, thank you. And Charles, will you also see this patient? Will you please come, will you drop down, will you please see this? I worked late. I moved to an apartment just a 5-minute walk from the hospital. So there would be no barriers to my coming over and seeing patients at night or on the weekends if I was needed. It was like, well, this this is needed. And if it's needed here in a very typical US hospital, it must be everywhere. The specialization had already occurred in Great Britain. And it just seemed obvious to me that this needed to be recognized because there was clearly the need among the patients. The general medical staff not only didn't have the skills, but were eager to have the help. And it was going to take far more than me to meet the needs just in this one hospital, let alone to do the research and the advocacy. And I needed to generate a larger number of physicians that could help me with that. It just seemed clear that specialization was the path forward because American medicine has generally followed the English pattern. And so that coupled with perhaps my own nature, which is in general, I ask, well, why not? I don't, the chief of oncology, Sig Weissman, when I first started, I wanted to have a consult service like I'd read about at Cleveland Clinic and what had happened in England. And he said, fine. And I said, well, all right, what committees do we need to go to? Whose approval do we need? And he said, Charles, sometimes it's better to beg forgiveness than ask permission. I'd never heard that phrase before. And that suited me just fine. I thought, well, that's a strategy. Well, that's a broad strategy for life. So instead of waiting for someone to say, well, please start specialty, the ACGME was just across the street. And I'd already been collaborating with Linda Emanuel at the American Medical Association about a national curriculum in palliative care. And so I just made an appointment with the president of the ACGME just to ask him about it. And he was quite willing to see me. Didn't matter to him that I was just a first-year attending. And he was very encouraging, even though at the time there was the word was there would be no new specialties. He said, Charles, of course there will be new specialties. It is inevitable with the immense growth in the knowledge that fuels medicine. The way that knowledge is made practically available to other physicians is through specialization. Well, that matched my experience. Here, I just made myself a specialist, at least in our little hospital, seeing consultations. And I was greeted by the other physicians with a sense of, oh, thank God. Of course, Charles, delighted. Please see my patients. Please see my other patients. They did what I said. The nurse that was with me, who was just a staff nurse from the hospice unit, but helping with the consults, they would do what she said. There was such hunger. That matched my experience. And so we started down the path. But the serendipity of being in Chicago, where much of organized medicine in the US is based, my willingness to, I could pay for a taxi to run over to their hospital. I could slip out of the hospital during the day and go meet somebody, which is the same pattern as the standard. When you go see a patient, you see them for real. You must see them in person to get the whole picture. When you see a physician who's asked you to see their patient, it's best to see them in person. Well, taking that one step further, and when you go see someone in their office, they will tell you the truth. And those same patterns that fuel good palliative medicine practice, starting with an open-ended question, tell me what you understand. That works just as well in committee meetings, meeting others. And it just happened I did that with the physicians that lead standard medicine in the US, including organized medicine, and it worked just as well. So the willingness to step forward politely, using the same tools, the same techniques that work in direct patient care, that was my secret, if there is a secret. being genuine, being warm, being curious, collaborating. That's what I brought to the field in the US. And right time, right place, right person, whatever it was. There are many physicians that were eager to be involved in this. And the experiences I had in Chicago mirrored those in Boston and Los Angeles and all over the country. So there were many who were willing to help in that process. And that's how it came to be.
Yeah, thank you for sharing that. And you make it sound so easy, but I'm sure it was. It wasn't. I
Well,
think
it's it, this is always retrospective, and in retrospect, we remember the good, and it's human nature to not remember the bad. But the what was surprising is, at least, and this is only for medicine, the physicians, as a rule, are a collegial bunch. All physicians, by and large, we are aware of our frailty, the things that we don't know, the things that we don't do well. We rely on our fellow colleagues. We've all been through the same training path, and that leads to an immediate bonding. So when I meet a new physician, when I was going through the process of helping find the way for hospice and palliative medicine to be a recognized subspecialty, it was the same patterns as when I met new physicians in the hospital. You talk about paths in training, you talk about who you happen to know, and medicine is a small world. When I went to the chairman of the American Board of Surgery, we started out with, well, who did we know in common and what kind of patient patterns had we seen? It was instant. When I talked to the physician who was head of the American Board of Medical Specialties, he was a surgeon. Same pattern. So the patterns, the overall patterns of medicine are very similar. And if one is not too dazzled by the title and looks to find the person who is in that position, just like when you go see a new patient, you want to find out who's the person. This isn't a person, this isn't a lung cancer patient. This is Mr. Tom Smith. Who is Mr. Tom Smith? Who is Mary Jones? Behind, who is she really? Well, the same approach works really well. And within a few minutes, you establish rapport, you find out what the issues are, you listen carefully, and then the path is clear after that. So that's my overwhelming memory. And at least in American medicine, the big divide is between the surgeons and those who don't operate. And in many hospitals, there's a divide between those two. Well, one of the big discoveries was that the surgeons, as a group, and this is in the political aspects, felt bullied by the internists. How shocking, how surprising. Well, it related to the politics of how the organizations are put together and the voting strategies and how the organizational decisions that were made 50 and 100 years ago and how it plays out. That was very useful to find out that the surgeons were not arrogant. They were, in fact, they had their own points of view and they didn't like being bullied by the internists. Well, how wonderful. Well, then they needed to be brought in. And that's why the specialty was open from the beginning to surgeons, not just internists. And it turns out the family physicians didn't want to be bullied by the internists and wanted in. And the pediatrics, well, they felt bullied by all the adult medicine doctors. Well, of course, they needed to participate. And when the final vote came, at the American Board of Medical Specialties, it turned out the anesthesiologists, the obstetrician gynecologists, the radiologists, the anesthesiologists, all of the separate board, well, they didn't want, they knew that there was wide acknowledgement that this area underlies all of clinical medicine, regardless of the specialty. And therefore, it is part of the training of all physicians, and that some physicians should have access to specialized training and recognition. So the pylon, when the vote came, of 11 different specialties organized in 9 specialty boards was a surprise to all of us. I started out hoping that just the internal medicine and family physicians would recognize it. But this recognition, this broad recognition by physicians in the best traditions of the specialty, of being doctors, that this is important. It's fundamental to being a doctor. Yes, there is specialized knowledge. Yes, there is specialized research that leads to a unique knowledge base that all physicians should have at a generalist level, and that some physicians should specialize in as consultants and to provide care for those who need it. There was no fundamental disagreement about that at the organized medicine level in the United States. So the challenge then became, well, again, so serendipity and this, what it was a welcoming, it was not a fight, it was welcoming. And then how do you organize in a practical way? All right, if that is true, then what are the mechanisms do you have for training and establishing that a particular physician has established specialist expertise in the field? That became the challenge. And again, it was not hard. One has to work through it thoughtfully, carefully, with so many people involved, so many different groups involved. It takes time, but there was no real struggle. And what became clear across the deliberations in the various committees, groups of physicians, the core issue, the core phenomenon that was determinative was those hospitals that had palliative care consult services, had strong hospice programs, that was there collaborating in the trenches, taking care of sick patients in the hospitals. In that collaborative nature among physicians, when deans of medical schools, chairmen of departments were together at committees, and they would say, you know, Joe, do you think we should do this? And Joe would say, look, Frank, in our hospital, we couldn't live without them. They help us every day. And Joe, who may have been in a hospital that didn't have this, but valued Frank as a colleague, would say, really? It's critical to you? Well, then we should have that too. In the end, it wasn't the intellectual arguments. It was clinicians talking to clinicians. You have this? It works for you? You really value them? Well, then I guess we should. So I'm so proud that at its basis, that is how medicine works. And it turns out I've learned it's not just confined to the US, it's that way all over the world. People have to try it. They trust their colleagues. They trust the people they work with. And when they adopt it, that's what leads to dissemination. So that's, medicine in the US, organized medicine, is over 5,000 years old. And it is based on these fundamental principles. You try and do your best. You work with your colleagues. You learn from your colleagues. You admit your mistakes, and you try and make it better going forward. And our field fits squarely in that long 5,000-year tradition.
That is just amazing how you put everything together. And there's so many dimensions to you as a person, Dr. Von Gunten. I just go back to the very basic. That there's this huge movement that has now started, in terms of hospice and palliative medicine being a field and the recognition of its importance. It all started with an experience of an intern admitting a patient at a hospice, and the
Yep.
nurse asking the question, you know, do you really need to do this, right?
Mhm, mhm.
And so it's fascinating to me how uh, such big movements start off. A very small seed is planted very early on in somebody's mind, right?
Mhm.
And then it just snowballs into something very big. So along with you, I also recognize the importance of different disciplines and clinicians who have sort of educated us and just ask us to pause and say, hey, do you really need to do this, or why wouldn't you do something different, right? um, do you remember that patient that you admitted that night?
Very well. Very well. The, um, this was a patient who was very close to death. Being able to recognize what I didn't know, what I felt uncertain about, and not trying to hide it, which there are plenty of role models around of people who bluster or try and hide that they don't know as much as they think they should. And it turned out that was an asset, not a liability. My willingness at 9 o'clock at night with this nurse to be, well, this is what I see. What do you see? What do you think this means? What do I think this means? And working to come together as a collaboration that we could be together. We wanted to take the best care of this woman we knew how. We wanted to make sure she was as comfortable as possible and receive the right care. There was no there was no yes antibiotics or no antibiotics. These are the rules. That wasn't the area we were in. It was, what is the right care for this person in front of us right now, all things considered, based on what we know. The Well, who can't get behind that? It turns out those are key leadership skills. What's our common goal? Can we get behind this? You bring your perspectives, I bring my perspectives. You have your experiences, I have mine. This is the information we have. And how do we come together? That's powerful. That's what led to the alignment, and it's fun. That's where the deep professional satisfaction comes from. Being aligned, trying to do the best for this patient, the family that's behind that patient, all the people that are watching. And when it turns out well, everyone feels like they've done a good job, that the hard work was worth it. The rest of my career, all, the deeply rewarding patients are all the same pattern. The successes in organized medicine are also the same pattern. Can we agree on a common objective that's not just intellectual, but there's an emotional component? You feel good about it. Across organized medicine, physicians are all, by and large, I found, motivated by the same objectives. And when you can be clear about that and not, and if there's a bump in the road, not trying to get involved in a tussle, but be curious. Oh, we've reached a bump. What's behind that? What are you thinking? Tell me what you understand. Those are overcome often so easily because it's often something you didn't expect or that you needed to know about. And it's not something to be overcome. It's, oh, well, it's obvious why this is a wrinkle. Now let's address that, and things move. So I'm struck with how the parallels between really good patient care, one by one. The same models are true for working with people way far away from the bedside, way far away from the clinic. The same patterns work.
Great. So the key, my takeaway is we got to work together to bring about change. And thank you so much for sharing your wisdom, Dr. Von Gunten. What we will do is we will have you back for another interview where I want to hear about your personal journey as a as an individual, and what you've learned through your experience. So we'll look forward to having you back again.
Thanks very much.
Thank you.